So I'm going to be measuring for jugular venous pressure. First, I'd like to note that my patient is at a 35 to 45 degree angle. Jacob, please move your head towards the left. Okay. I am looking at the internal jugular vein at the point of maximal pulsation, venous pulsation. I'm also finding the sternal angle. Okay. Yep. Thank you. Okay. This is less than 2.5 centimeters. Normal JVP is less than 3 centimeters. Next, I will first listen for any bruits at my patient's carotid arteries. I will do this prior to palpation. Jacob, please hold your breath. Okay, hold your breath again. Thank you. I was listening for any swooshing sounds, which would indicate bruits. There was no swooshing sounds. Next, I'll palpate each carotid artery one at a time. I'll do this one at a time to prevent compromise of cerebral perfusion. Okay, I am feeling for quality, rhythm, rate. Okay, carotid arteries feel symmetrical and brisk, which is a normal finding. Next, with my fingertips, I will palpate for heaves and lifts at the parasternal left region. Okay. No heaves or lifts. This would indicate ventricular hypertrophy. Next, I will use the balls of my hands and I'll feel for thrills. Thrills would be like a vibration sound, and I'm doing this over the valvular areas. Okay. Next, I will identify the 5 precordial auscultation landmarks. The aortic, which is second intercostal space, right sternal border. The pulmonic, second intercostal space, left sternal border. Erb's point, which is third intercostal space, left sternal border. Tricuspid, which is fourth, fifth intercostal space, left sternal border. And then the mitral, which is fifth intercostal space, mid-clavicular line. And then below the xiphoid process is the epigastric region. Next, I will listen for the apical impulse and measure that. Jacob, please lie on your left side. I'm grabbing my ruler again. Okay. Yeah. Okay, apical impulse is 2.5 centimeters, which is normal. Next, I will auscultate with the diaphragm of my stethoscope. Jacob, please lie on your back. I will use the diaphragm of my stethoscope and listening in these 5 regions I identified. I'm listening for S1, S2, and split S2 if pathologically possible, murmurs, gallops, or rubbing. Next, I'll use the bell of my stethoscope and I'll listen in these same regions, but for S3, S4, any low-pitched murmurs. Okay? And I'm doing this lightly. Okay, no murmurs heard. Excellent. Okay, next, I will listen for any mitral murmurs. I'm going to do this with the bell on my stethoscope. Jacob, please lie on your side again. Okay, so mitral murmurs would sound like a low-pitched rumbling during diastole, which I do not hear. Okay, next I'll listen for aortic murmurs. Jacob, please sit up. I'm going to use the bell of my stethoscope yet again. And I'm listening at the second intercostal space, best heard at the aortic or Erb's point. Okay, Jacob, please exhale and then hold your breath. Okay, excellent. And I did not hear any early diastolic decrescendo. Thank you.